this talk, again, is why genetics still matter. As I noted before, this is sponsored by the Foundation for Women's Cancer with educational sponsorship support from Teal and from the NYU Langone, the Perlmutter Cancer Center. So thank you very much for that. I'll explain momentarily why I gave this talk this title. What we know about ovarian cancer is constantly changing, and this is a great thing. This is the reason why we keep having these courses and why some of you have been to so many of these courses and heard what you think is everything that's on this schedule already. And I see some of my favorite people here that have probably been to all 5 of the NYU courses. But the reason that we keep having these courses is because things change and genetics do still matter. So when I speak about why genetics still matter, I'll speak about genetics in general, cancer genetics, and how to think about ovarian cancer genetics. Now, in picking this topic, when I'm picking a topic for these courses, and I do love having these courses, I love speaking at these courses, but I ask a lot of women that I know what they'd like to hear about. As I mentioned, feedback is really key. And I've heard before some buts about, the genetics talk, which usually is the first talk, honestly, at these lectures. And these are some of the buts. So, some people say, but I already have cancer. Why do I care about genetics? Because, I have it already. Certainly the genetics don't matter at this point. Or they have been tested, but I've already been tested and I'm negative. But I don't want to burden my daughter, sister, mother, family, but I've already heard this. But again, genetics are changing and things are changing, and hopefully you haven't heard all of this already. So to step back for a second, there's a couple different things we're going to talk about. Now, cancer is universally a genetic disease because cancer is the result of accumulated mutations in DNA, either inherited or acquired. So this is a little bit complex. So all cancer is genetics. And if you want to think about what a gene is if you have a cell, and then within the cell there's the nucleus, the center there. Going further, within the nucleus are chromosomes, and on the genes are part of the chromosomes. And a gene is a portion of DNA that codes for a specific protein. Now, genes contain the infrastructures for making proteins. I'm trying to explain why I'm saying everything's genetics, and then I'm going to explain what I'm talking about. So basically, if genes, which are DNA, lead to RNA, and that then is translated and that becomes protein. And there are a number of factors, be them environmental, lifestyle, or disease, which can cause errors to occur in that process. And that is how cancer sort of develops. Now, as I said, all cancers are genetic. So all cancers involve mutations. But if you have hereditary cancer, as shown on the top, you start out with a mutation. So you're born with one of the mutations. So you start out with a head start towards that. So does that make some sense? So it's always part of your genes. But when you're thinking about genes and you're thinking about genetics, I'm talking more about genetics as the hereditary aspect of it, the things that you inherit from your family. And that brings us back to, as my son said, 2nd grade, but I didn't learn this in 2nd grade, genetics. So, Gregor Mendel and his peas, where he noticed the peas had different traits, and he found that some were dominant and some are recessive. And you might remember it this way in these Punnett squares, because genetics is the study of hereditary and the variation of inherited characteristics. And on your left are his pea plants, and then on the right is something we all know about, the brown and the blue eyes. Remember, you inherit your eye color from your parents. If you have brown eyes, you could have 2 brown genes. You could have a brown gene and a blue gene. 2 brown-eyed parents can have a blue-eyed kid because they could have recessive genes. So when we're talking about genetics, there's traits, and then there's cancer. So you will inherit the gene for brown eyes, and you will have brown eyes. But with cancer, you inherit a gene for cancer, and that means you have a genetic predisposition to cancer. You may or may not develop cancer. So you have to have an eye color, but you do not have to have cancer. If you are born with that mutation at the beginning, but don't go through those other mutations, you might not have cancer. So 2 important concepts to think about with cancer genetics. One is autosomal dominant, which what that means is if you get one of the cancer genes, you will express it. It's sort of the brown eyes. It means you are prone to it. I don't know if I made that clear. if you get a mutation in a gene, you are more at risk for getting that cancer. But just having that gene does not mean you will get cancer. It's called incomplete penetrance. Everybody that has a genetic mutation does not get cancer. So a mutated gene can be passed down from either parent to child, and some people don't necessarily realize that they can be passed from fathers as well as mothers. You can pass them to sons as well as daughters, and so this talk does apply to both men and women. When you're talking about ovarian cancer, obviously it applies to women, but there are other associated cancers that are important that are associated with the gene. So how we used to think about cancer genetics, and I actually pulled this slide from a talk I gave for one of these maybe 10 years ago. We used to say that 10% of ovarian cancer was hereditary and the rest of it was sporadic, which means it had nothing to do with your heredity. And among the people that had hereditary cancer, the vast majority were ascribed to BRCA1 and 2, which you might have heard of before, and the other 5 to 10% were to HNPCC, which Pamela was mentioning. And that's how we used to think about it. However, over the past couple of years, we've learned a lot more about a lot of other different genes that cause cancer. And this data, I have to pull my glasses up again, sorry. This data, basically, this was looking at a whole bunch of women with ovarian cancer from the University of Washington, and they just tested all these people for a whole bunch of different mutations. And basically, it was found that actually, in this cohort, 25% almost of patients had mutations, and among these, 6% had actually non-BRCA1 and 2 mutations, and these were not all Lynch. Other genes accounted for almost 30% of cases with germline mutations. And really importantly, 1/3 of cases with mutations had no family history at all. So people used to say, well, I had ovarian cancer, but there's no other ovarian cancer in my family, so there's no way it's genetic. However, that you can't use that to say it's not genetic because we're learning more and more now. The other thing we used to say is that, well, if you have ovarian cancer and you were young when you were diagnosed, it's most likely genetic, but it was actually found that 40% of these people were over the age of 60, which is the average age of diagnosis. So you can't use any factor about your personal ovarian cancer to say, I'm not a genetic risk. Every woman should be tested. I think I have about 8 slides that say the same thing about that because I feel very strongly about that. This is actually an interesting study. It looked at mutation testing among almost 1,500 women with ovarian cancer that were all treated similarly, and basically here, BRCA1 and 2 mutations were 14% and non were 6%. It's sort of repeating the same information, but it is true. There are a lot of other mutations that are associated with ovarian cancer. And this is a list of all the mutations, and I don't mean to overwhelm you with a lot of words and numbers and such, but the point of it is that 29% of mutation carriers have mutations in non-BRCA genes. So it's not only BRCA1 and 2, and if you're just tested for BRCA1 and 2, there's, I guess, a 30% chance that there might be another mutation you have that you do not know about. So all women with ovarian cancer should have genetic counseling and be offered genetic testing. Genetic counseling is the process by which you sit with a counselor and she talks, I'm sorry, I said she because my counselors are all women, but they don't have to be women. They talk with you about your heredity, and then they talk to you about the test that you might want and what the implications of that finding are. I feel really strongly that you shouldn't just go to CVS and buy a test. There isn't one now, but there will be in a year. I'm sure there will be. The counseling is key to understanding the results of your genetic testing. Now I'll speak a little bit about ovarian cancer genetics, first for women who have had ovarian cancer, and then for the family members of women who have had ovarian cancer. So no gene is an island, and the thing that I wanted to mention, that big pie chart with all the different colors in it, when you look at those genes, they're all involved in sort of the same repair mechanisms. So basically, what has been found over this time is that a lot of those mutations are involved in something called homologous recombination. A lot of ovarian cancers are now associated with something called homologous recombination deficiency, or HRD, which you might hear sometimes. And in fact, there will probably, actually, I don't want to say it right now because I have a slide and it's not an endorsement, I promise. But homologous recombination deficiency is the loss of the ability to repair double-stranded DNA breaks, resulting in increased susceptibility to DNA damaging agents. So what that means is that if you have homologous recombination and BRCA1 and 2 are associated with that, as are a lot of the other mutations that were on that multicolored pie chart, it means that your DNA doesn't know how to repair itself as well as some other people's DNA, and that is one of the reasons why cancer is more likely to form. Additionally, it means that you probably have a longer time that you will respond to the drugs that we have, because the same reason that your cells were more susceptible to cancer in the first place, they are more likely not to learn to become resistant to our treatment. So even if you have it, once you have a mutation that predisposed you to cancer, there is evidence, which I'll show momentarily, that you will live longer. So defects in homologous recombination impact prognosis in ovarian cancer. And one thing I'm not going to get into a lot is that there are different ways that you can have defects in homologous recombination. It can be through something you inherited, which is what I'm talking about today, but it can also be a mutation that occurs in your tumor. And those are called somatic mutations, and that's sometimes when tumor is tested. It's not seen in your blood, but it can be in your tumor. And you can still behave like a person with a genetic predisposition to cancer if you do not have a blood mutation that you test for, because maybe your tumor has that finding. And I'm not going to get into that a lot, but there are more ways. What I'm trying to say is, if you went to have genetic testing and it was negative, it doesn't mean that you do not have homologous recombination deficient cancer. There are other ways to look for it. Basically, in multiple studies looking at survival of people that have homologous recombination deficiency versus not, the people with homologous recombination deficiency do better. And this is the same sort of thing, and it applies to all mutations that are associated with homologous recombination, BRCA2 the most, but all mutations. And so basically what has happened in the past couple of years is that BRCA1 and 2 were discovered in the 90s, and then some drugs that sort of capitalize on their deficits. The class is called PARP inhibitors, but they were developed during the 2000s. And in December 2013, olaparib was the first one that was approved for women with BRCA mutations. And this is really interesting because this is a totally different way to look at cancer. This is truly targeted therapy, and there will be a talk this afternoon on personalized therapy for ovarian cancer, and I'm sure that will be discussed at that time. But one thing that's important to think about is that the testing for genetics, if you are tested for genetics for ovarian cancer, it can have implications for your treatment in the future should you need it. So, and we also are learning that different patients do well with different kinds of treatments. So the way that with breast cancer, people are tested right away for HER2/neu or even hormone receptors, that is what I believe homologous recombination is going to be like. You will have an ovarian cancer diagnosis, and you'll get tested for homologous recombination, and that will guide your treatment. So it's going to be, it will end up being a little bit different. It's not going to be everybody with ovarian cancer gets the same treatment, but as things get more personalized, if you have a feature of this homologous recombination, then you will get different treatment. So there are 4 PARP inhibitors. The first one, olaparib, is the one that is FDA approved. I just put these up there because people always are interested in the names. The olaparib, rucaparib, velaparib, niraparib. So those, they are all, they're all in trials. Actually, olaparib can be obtained off trial, but all the other ones are in trials. And they represent really a breakthrough in the treatment of ovarian cancer. I mentioned HRD in general, and I mentioned the idea of getting your tumor tested and yourself tested right after diagnosis. There will be being developed some companion diagnostics, which this is one company that has it, and this is not an endorsement, but it has a decent graphic here, which basically says you have a cancer cell with homologous recombination. You are treated with a DNA damaging drug, and the drug causes permanent DNA damage that leads to cancer cell destruction, meaning that basically you have HRD, so you pick an agent that's going to work better in that situation. So this is probably going to be something that's available in the near future. Again, all women with ovarian cancer should have genetic counseling and be offered genetic testing. Whether genetic counseling will be part of having your tumor tested as well is not yet known. That is something that is, at this time, if you get your tumor tested, it does not require testing, but that may be something that happens in the future. Now, why aren't all women with ovarian cancer undergoing genetic evaluation? Because I said this a lot of times, and actually, I think in the past it used to not be covered for all women with with ovarian cancer, looking at things like, how your cells look under the microscope, how old you are, what your family history was, but now it is universally recommended and actually covered. So a study from Dr. Jazari's institution, MD Anderson, showed that 89% of women with ovarian cancer are willing to have genetic testing, but another study showed that only about 19% of ovarian cancer survivors have actually undergone genetic evaluation. And a lot of this is thought to be due, there is a psychological impact of genetic counseling and testing, and it's also, it's not that easy to get in. People don't know where to see a genetic counselor, how to find somebody. Don't necessarily go back to the buts that I had on that earlier slide. So actually at NYU we're doing a pilot study looking at the feasibility of genetic testing at Diagnostics for patients with ovarian cancer, where we're making it as easy as possible to get in with the genetic counselors, and we're looking at a lot of measures of stress and such that this causes, and we've found a lot of very interesting things, and hopefully it will become easier and easier for women with ovarian cancer to get tested. So I mentioned before that we used to think of just 2 genes, and now we think, or two plus a couple genes, now we think of a whole lot more of genes. And we used to test for 1 gene at a time, basically, but in June 2013, the Supreme Court ruled that Myriad could no longer have the patent on genes, so a lot of companies came out with what we call panel testing. And what this panel testing does, it basically allows you to test for a whole lot of mutations at the same time. It's called next generation sequencing, and it is rapid, it's cost effective, and you can check for virtually an unlimited number of genes. There are some downsides to this, which you can get information that you don't know what to do with. You can find out you have a mutation in a gene that nobody knows what it means, and that can be stressful, so I don't want to necessarily endorse this. This again brings up the concept of the importance of genetic counseling. You don't want to do this kind of testing, again, from a drugstore. You need somebody to explain your results to you. And we, when people say, well, I've already tested and I'm negative, we actually looked at our patients who had been tested and were negative and got retested, and we found that about 7% of these patients ended up having a pathogenic mutation, meaning something that could be helpful for their treatment and something that could be helpful for their families. So in general, I do personally advocate retesting. Again, I do it with a genetic counselor. If you've been tested, if your testing was before June 2013, you probably did not have panel testing. So in that situation, it would be a good idea to speak to your doctor about that. Now again, I mentioned the idea of finding information you don't know what to do with, and 42% of these patients had findings that were, again, meant nothing, but caused stress. They're called variants of uncertain significance, so there is certainly a downside, and I'm sure we're going to learn more and more about this uninformative findings. So it's something that is not all good, but if you want this information, you may be able to get it. Now, in the slide I just presented, I said 7% of patients with prior non-informative testing. This was all comers. This was a lot of mostly breast cancer patients, but we know from ovarian cancer patients that 29% of patients will have genes that are not BRCA1 and 2. So I think the panel testing is even going to be more important for ovarian cancer patients. Survivors, sorry about that. Now I'm going to move on to your family, and this is not a conflict of interest, but I believe very strongly in genetic counseling. So this is where it's really imperative that a genetic counselor is involved in your decision making. So let's say you get tested. How does this impact your family? If your test is negative, this is where this does not mean that your family is not at risk. It means we don't have the numbers. We can't say your family has a 40% chance of this or 50% chance of that. It's not as informative. I would call that non-informative more so than negative, again, because of how things are always changing and we're learning more and more. if your test is positive and then your child gets tested and your child has a negative test, you've taken a huge burden of stress off of that person because they do not have the same genetic risk. And if your family member is positive, there are things that people can do to prevent cancer. Your daughter could save her life if she's tested and she has a mutation and she decides to have, take out her ovaries younger, have her kids younger, go on birth control pills. There are a lot of things that people can do. And if you view it as empowering rather than stressful, and it's my belief the way that things change that there'll be something very easy to do in a short amount of time that can help people, I really think this is really important. The whole concept, this is really cheesy, so bear with me. There's a whole concept of cascade testing, and this makes me think of the whole thing, old shampoo ad, I told 2 friends and they told 2 friends and so on and so on and so on. So that's cascade testing. The way I would think of it here, so let's say there are supposedly going to be 200 and something people here today, and let's say 10 people here decide after this that haven't been already tested, decide to get testing, and 3 of them, based on that pie chart, have mutations, and they tell their families, and let's say 2 people from each of those families decide to get tested, and 3 are negative, they have huge sigh of relief, and 3 are positive, they can do something to prevent cancer. Look at that. I mean, so I can't say it enough times. I'll stop talking soon, don't worry. What we know about ovarian cancer is constantly changing. So just to sum it up, rather than the general conclusion side, I thought I would address the buts again. But I already have cancer. Genetic results can guide treatment and predict prognosis. But I've already been tested and I'm negative. Consider panel testing with a genetic counselor. But I don't want to burden my daughter, sister, mom, empower her to save her own life or relieve her of the cancer stress she has now. She thinks she has it until she thinks she has it, basically. But I already heard this. Remember, this is a dynamic field. It changes literally daily. It's really hard to keep up with it, but that's a good thing. And I really wanted to thank you very much for your attention early this morning. I wanted to thank the Foundation for Women's Cancer, the Society for Gynecologic Oncology, Tell Every Amazing Lady, and NYU Langone. Thank you so much.